Good day, my name is Imelda Williams. This presentation will focus on abnormal radiographic appearances of the chest. I've separated it into two parts, so the first part will be part A and then part B will follow after that. The resources that I recommend is from Clark and Dux, and the main ebook is Chest X-rays for medical students, and then part 3 on common conditions. You will also have links to the other ebooks as well. I've uploaded additional resources, and one of those resources is the ILO International Classification of Radiographs of Pneumoconiosis. So that's just for yourself, so that if you should use that or have a need for that, then at least it's available for you. In addition, there's the Ransker Clinical Decision Rules, and the only module that they have for the chest is on a suspected pulmonary embolism. So I trust at the end of this lecture, you should be able to identify the abnormal radiographic appearances on both adult and pediatric chest projections, as well as appreciate how important it is that you develop a systematic approach, because the chest X-ray is not easy to interpret. And you should be able to identify significant radiographic findings, which will include both traumatic as well as common pathologies in both adult and pediatric chest X-rays. So there's a very simple approach to identifying chest abnormalities. The first thing you need to think about if something is too white. An example of that, for example, is with a pleural effusion, which you will have seen before, and that is of course where the pleura has now been filled with fluid, and of course replacing some of the lung as well. And then the second one, if something is too black, and again that's where there's a pneumothorax and where a part of the lung has been replaced by this abnormal air in the pleura. When something is too big, for example with cardiomegaly, and if something is in the wrong place, for example with dextrocardia or situs inversus. So when you evaluate the lung fields, check the margins for pleural thickening, masses, or pneumothorax. With patients with COPD, the lungs are normally hyperlucent and causes flattening of the hemidiaphragms. And things that you should search for is for an area of bullae. So an area of bullae will have a densely black area of the lung. And then also note in presence of shadows from CVP lines, nasogastric tubes, interpulmonary drains, etc. So pneumothorax, the uncomplicated pneumothorax, there's no midline shift with an uncomplicated pneumothorax. The things you need to search for is for the absence of lung markings. So if we look at this chest on the right side and we compare to the left side, we can see that the left side has got lung markings, whereas on the right side the majority of the lung has no lung markings. You also need to search for signs of a visceral pleural line, and then sometimes where it's a small pneumothorax, search for a curved pleural lung at the lung apex. So tension pneumothorax is due to accumulation of air under pressure in the pleural space. Main thing to look for is for mediastinal shift. So if we look at this case, we can see that the right lung is very big, but it also has pushed the mediastinum to the right side. And when we compare the right lung to the left lung, we can see the left lung has lung markings, whereas the right side has no lung markings. So there the lung has completely been pushed away and has collapsed. And we can also see that the trachea has also been displaced to the right side. Of course, don't have to tell you that this is a medical emergency. And now looking at rib fractures, it's only important for what they can cause. So rib 1 is normally associated with facial fractures. If you have fractures of ribs 1, 2, and 3, This can be in cases where there's serious trauma and can lead to ruptured bronchus. Ribs 4 to 9 can cause a pneumothorax or contusion of the lung, and then ribs 10 to 12 can cause lacerations of the liver or the spleen. So in rib trauma, here we can see in this case on the right side that there are numerous rib fractures, and we can also see when we compare right to left that there is contusions as well. Very difficult to see whether there is a pneumothorax on that case. And just to go back again, when you look at rib fractures, so if you have trauma, don't forget to look at all of the bony structures, because here we can also see that there is a fracture, displaced fracture of the clavicle, and it's comminuted. Now focusing on pleural effusion. With pleural effusion, and especially when the patient is, of course, in an erect position, the costophrenic angles are obscured, and they normally have a meniscus-shaped appearance, and the lung base become very white. You could have an ipsilateral lung collapse if the effusion is very big, and with massive pleural effusion, you can also have mediastinal shift. So it's clear with this case that there is a large right pleural effusion, and on the lateral view we can see that it affects the right lower lobe as well as the middle lobe. This patient has tracheal rupture, and which has resulted in pneumomediastinum, so we can see the air that tracks around the mediastinum, and you can also see that there is it has affected both of the lungs. In this close-up view, you can actually see how the air is tracking around the mediastinum, and not as clearly seen, but there is this continuous diaphragm sign as well. It's important to look at the soft tissue if there's trauma, and in this case we can see on both sides that there is abnormal air within the soft tissue next to the rib structures, and this of course is surgical emphysema. And here we have a patient with a pneumothorax, so you can see there is no lung markings, but we can also see that there's a fluid level which indicates that this is hemopneumothorax. With pericardial effusion, normally the heart ratio is quite massive, and the lungs do appear normal, so the heart takes on like a water bottle or globular shape. The silhouette sign is a very useful sign for detecting and localizing abnormalities, and it was first described by Felsen. So when the alveolar infiltrate develops, the air is replaced by fluid, and the fluid does not create a contrast with the vessels, and therefore the boundaries of the lung then become obscured. And this particular structure that is obscured indicates which portion of the lung is involved. And this disappearance of the lung border, for example, either the mediastinum or the diaphragm, is called the silhouette sign, and it is most commonly seen in cases of pneumonia. So I've given you here a slide where when you see a silhouette sign, where you should be able to suspect the abnormality should lie. So if you have a loss of the right heart border, then the abnormality will be the right middle lobe, as that is in contact with the right heart border. And then if it overlies the right heart border itself, then you should be considering the right lower lobe, and that's in the posterior mediastinum. If there's a loss of the aortic knuckle, for example, then it's the left upper lobe, and if it's a loss of diaphragm, then it's the lower lobes or pleura. So in this case, we have the absence of a silhouette that should normally be seen and affecting the lung fields, and this therefore makes it very dense. So what do we have? So this patient, if we look very carefully, we have lost the right hemidiaphragm. We've also lost the right heart border, so it means it has affected both the middle lobe as well as the lower lobe. So this patient has also got some right upper lobe as well as middle and lower lobe consolidation. So if we know where the silhouette is absent, that will point towards the lobe or the segment of the lung. However, remember that there are limitations to the silhouette sign. The cardiac border can be lost on a PA chest X-ray, especially if there's pericardial fat pad that obscures the heart border. And also in patients with pectus excavatum, this may obscure the right heart border. Next, pulmonary collapse. There are direct as well as indirect signs of collapse. So first, looking at direct signs. With direct signs, look for things such as displaced interlobar fissures, and this will be towards where the collapse is. If there's crowding of bronchovascular markings due to volume loss, or very important is to check whether there's previous chest X-rays and whether you have shifting of marker structures, for example, a granuloma. With indirect signs of collapse, so with hilar shift, there will be depression or elevation of the hilum, and then also diaphragm shift or mediastinal shift, and then look for changes in lung size or lung volume. So the kinds of changes in density. So atelectatic changes is where there's airless lung with increased radiopacity. The adjacent lung becomes hyperinflated, and that increases the radiolucency. You would find volume loss, which leads to vessels in the atelectatic lung becoming more crowded, and then you will have compensatory volume increase as the vessels in the adjacent lung is further apart. On this slide, I've given you the types of collapse patterns that you can look out for. So, for example, with the right upper lobe, the trachea has deviated to the right side, and the horizontal fissure is then pulled up, so it's not at the level of the sixth rib. And if we look at the left upper lobe, ill-defined opacity, and then also if you remember that the upper lobe makes up the most of the left lower lobe, so having sharply defined posterior borders as well. So this is a very useful slide to consult if you are looking at possibilities of collapse. So then with lobar collapse, consolidation may be associated with opacification and loss of volume. And airway obstruction results in deflation of the affected lobe. Mass effect can occur with adjustments. So on this image that we have on the chest X-ray, we've got left upper lobe consolidation as well as collapse. So with right upper lobe collapse, here we have the tracheas deviated towards the right, and then there's an increased density in the right upper zone and lung apex. And this elevation of the left higher hemidiaphragm due to the volume loss. With right middle lobe collapse, we've got the right cardiac silhouette sign where we lose the right heart border. On a lateral view, it takes on a triangular opacity, and this stretches then from the hilum to the costophrenic angle on the lateral of the chest. With the left upper lobe collapse, the left upper lobe collapses forward, and it casts a veil-like appearance, opacity over the left hemithorax. It is normally therefore more dense towards the apex. The lower lobe expands behind it, and as well as the aortic knuckle, which lies towards the back of the chest. Characteristically, this will remain visible. So with left upper lobe collapse in this chest X-ray, we can see there's an indistinct density in the left upper zone. We have the silhouette sign where we've lost the left heart border, and the mediastinal shift, there's some mediastinal shift towards the left. On the lateral view, there's increased areas of density in the retrosternal region. With left lower lobe collapse, there's volume loss, and then also an elevated left diaphragm. So on the lateral view, we can see that the collapse is posteriorly as well as inferiorly. So left lower lobe collapse, then we have mediastinal shift towards the left side, and density become visible behind the heart shadow, and you have a silhouette sign where the medial portion of the left hemidiaphragm is absent. So left lingular collapse is a sign of a left cardiac silhouette sign, and it's a faint shadow behind the heart. On the lateral view, it takes on a triangular shaped density, so it looks very similar to that of a right middle lobe collapse, but normally it's not as obvious. So here we have a lingular collapse, so fairly large area in this case. So this is silhouette sign, and then on the lateral view, it takes on that same triangular density as what we saw with the right middle lobe. There are some other signs as well that has been described in terms of collapse of the lung. And the first one I want to talk about is the Golden's S sign. And this is where you have a combination of the upper lobe collapse as well as a hilar mass. And the combined contour of the ataletic lung with the mass forms a reverse S-shaped sign, which is visible on the PA chest. The hilar mass is most often malignant. The next one is Luftsichel sign, and this commonly indicates left upper lobe collapse, but it can also be on the right upper lobe, and it's seen as a para-aortic crescent of hyperlucency. So on the PHS X-ray, you can see there's the collapsed lobe produces this hazy opacification, and the left hilum is elevated. So the final of these signs is the spine sign, and this is seen in the lateral chest X-ray where the lower lobe has collapsed. So you have this density over the lung tissue, and this is over the lower thoracic vertebra, and that is called the spine sign. So this is now the end of part 2. So once you have reviewed part A, please review part B, and that will then conclude the abnormal chest appearances.